got interested in this area because I noticed for first mothers, looking after a new baby for a new experience can be very challenging. But when you've got two, it's exceptionally challenging. And if you're just recovering from a cesarean section, it can be very difficult indeed. And I noticed a lot of my patients who had cesarean sections really struggled in the postpartum weeks and often had problems with depression and anxiety. And so I developed a very strong clinical interest in enabling them to have vaginal deliveries. And that's what I'm going to talk about today. Next slide, please. Next slide, please. So my aims are to make this very much a practical talk. I've got some papers and research that we've done at my hospital, but I really want to keep it to a clinical, practical talk because that's of the most help for clinicians who haven't got a lot of experience in this area and want to have experience in this area. And I want to provoke thought and highlight the case for vaginal delivery of the second twin, because I think it's something that a lot of people feel a little bit anxious about as clinical providers, but it's actually a very simple and straightforward thing. Next slide, please. So this is some research we did at our own hospital. Sarah Easter was a fellow of mine, and we hypothesized that the more you do, the more you'll be better at doing something, and therefore the greater your volume, the greater the likelihood you'll have a vaginal delivery. Next slide, please. You will see from this that this is the volume of twin deliveries by cesarean section in a hospital by the size of the hospital. And going to the next slide, please. And we suspected, if you just press the next slide, we suspected that as you did a greater volume, you would have a lower C-section rate, but we actually found it was the opposite. And so we got very concerned that the trend is towards cesarean delivery rather than vaginal delivery. And so we highlighted trying to promote vaginal delivery in our hospital for some years. This was all done at the Brigham and Women's Hospital in Boston. Next slide, please. So what is your usual practice? I think everybody practices cesarean section when the first baby is breech, although I'm seeing some papers appear suggesting that it's safe to do this vaginally, particularly in multiples. The reason we don't do this practice is because we're worried about locking twins, but locking twins are actually exceedingly rare. It's warned that if you have locking twins, it's actually an irreparable clinical situation and can only be solved by a destructive procedure. But I've actually had 3 sets of locking twins in my life, and in all 3, we were able to disengage the presenting head and have a normal vaginal delivery. I think with vertex twins, most people aim for vaginal delivery, and if not, they certainly should be. But however, when you get to vertex breech and vertex transverse, there tends to be an increasing incidence of cesarean section. It's interesting when you have breech, everybody does cesarean section, but actually there is no risk of locking twins in breech. So that's one of those puzzling things that we can't find an explanation for. Next slide, please. So what do you do and how do you do it? And I'm really going through this talk to promote your interest in encouraging vaginal delivery for twins. Next slide, please. So this is an evidence light zone, and you'll find there's a lot of papers, particularly when you get to the vaginal or the vertex breech presentations, that people advocate either cesarean section or vaginal delivery. However, when you look at all of these studies, they almost never stratify the results. They don't look at nullets compared with multips. They don't look at induction compared with spontaneous labor or any of the other things that I've listed here that can often make a great difference to the clinical situation and your likelihood of a successful outcome if aiming for a vaginal delivery. Next slide, please. So when we look at it, we find that everybody attempts this for vertex, but we would actually like to encourage more people going for vertex breech presentations. And that's what I'm going to come to with the rest of the lecture. Next slide, please. What do you prefer? Now, most people prefer vertex because they imagine it's going to be easier, less anxiety provoking, less stressful, and more likely to have a good outcome. I actually, having all my practice being twins or the vast majority for many years now, I actually prefer vertex breech. And the reason, there's a number of reasons for that. Firstly, the last thing the mothers want is a vaginal delivery of the first baby and a cesarean delivery of the second baby. And that nearly always happens in vertex presentations. And because it's determined by the length of time that passes between the delivery of the first baby and the second. And delivering vertex tends to be a less invasive or a less aggressive procedure, and therefore there tends to be more time. And that's just time for things to go wrong, for there to be vaginal bleeding, for there to be an abruption, and for there to be a concerning CTG. I actually much prefer vertex breech, because with the second baby, you just reach in, grab the second one by the foot and pull it out. And therefore the time in between the delivery of first and second babies is much less, and you're much more likely to have a successful, uncomplicated vaginal delivery. Next slide, please. This is some work we did at the Brigham. This was done with our own population. Next slide, please. And you'll see what we found. This is just looking at successful vaginal delivery between vertex and vertex non-vertex breech. And if you look at basically look at them as a column, and you'll see with vaginal deliveries, although there were so much more for nullips, 207 of 296 patients had a successful vaginal delivery, but that was only 70%. And 85% of the vertex breech babies had a successful delivery when that was planned. And the reason for this is entirely that short interval between the first and second baby. And when you can look at this, when the first baby was vertex and the second was breech, when you're after delivery or non-vertex for the second delivery, you can see that there's a much higher rate when it's vertex breech, because that was the planned delivery mode from the first place. Next slide, please. So this is the paper that's changed everything worldwide. And this is John Barrett's paper, where he did a large multi-center international trial randomizing between planned cesarean delivery and vaginal delivery. And this was carried out, it was published quite a while ago now in 2013. And I think this really changed everybody's practice, because this is science telling us that we should be aiming for a planned vaginal delivery in vertex and non-vertex, or vertex, and vertex, non-vertex twins. Next slide, please. You'll see from this that of the two groups, I'm just going to go through this very quickly. It was a randomized trial, so there was no significant difference between the two groups. Next slide, please. And you'll see there was no difference in outcome, either for the fetus, the neonate, or the mother, whether you had a planned cesarean delivery or planned vaginal delivery, and the difference was identical for both, with no significant difference. And this was the paper that led to a major change in practice worldwide. Next slide, please. However, and we can just click through the slides here, you see there's 4 papers. There's a number of papers that a lot of people know. There's one more. And these say the opposite. However, these are all retrospective cohort studies. None of them were actually randomized trials. So our highest significant standard of clinical science of the RCT is that we should be aiming for vaginal delivery. Next slide, please. These are the 2 authors of the 2 major papers in this area. It's John Barrett on the left, and this is Gordon Smith on the right. Both of them are friends of mine. John's in Canada and Gordon's in Cambridge in the UK. And they both argue their case. Gordon is for cesarean delivery. It's actually quite interesting because Gordon himself is a second twin, who I believe was a vaginal delivery. And John, due to his RCT, argues that the best mode is vaginal delivery. Gordon will say it's because if in John's study, because all gestational ages were grouped together, it doesn't have enough power to come to the right conclusion. However, there have been many stratified analyses by gestational ages still saying no significant difference in outcome between the baby or the mother for vaginal delivery versus cesarean section. Next slide, please. So this is now the standard of care dictated by the American College of OBGYN and the Society of Maternal Fetal Medicine. Next slide, please. You will see from this, it says perinatal outcomes for twin gestations in which the first twin is cephalic, they're not improved by cesarean delivery, regardless of the presentation of the second baby. And we should be aiming and we should be counseling the mother to attempt vaginal delivery with all vertex presenting twins, whether the second one's breech or not. Next slide, please. So I'm going to go through a quick clinical case with you. This is just to go through the practice for vertex twins. You're on call at night, you're coming onto your night shift, and you've got vertex twins, 2,338 grams, 2,194 grams. Discordance is 6% between two normally grown babies. How are you going to do it? This is a nulliparous mother. Next slide, please. And this is what you want to do, how you're going to approach it. And I've trained all over the world. I trained originally at Guy's Hospital in London, and then I was at the John Radcliffe in Oxford, and then I came to America, practiced in Virginia, then Manhattan, and then Boston. And I found that everybody has their way of doing it, and everybody thinks their one way is right. But there's actually a number of different well-recognized techniques. And this is all anecdotal evidence. This is clinical practice, not research. And I found that these different methods, rather than using one method for all, you're better adapting your method to the particular situation you're in. Next slide, please. Next slide. That's right. So the one thing the mother doesn't want is a C-section for the second baby, having had a normal delivery for the first. Certainly doesn't want to have a vaginal delivery for the first, an episiotomy and a laparotomy. And she doesn't want to have unnecessary morbidity for herself. Next slide, please. So how do you approach the case? And this is how I think every case is different. And these are the things I always want to know. Is it a nullip? Is it a multip? I'll manage them totally different. How big is the second baby? What's the amniotic fluid volume for the second twin? What's the lie of the second twin? What's the anesthesia? And because these are all things that are going to affect my technique I use for delivering the twins. Next slide, please. What are you going to do? There's lots of different techniques. Are you going to do it in the labor room? Are you going to take the patient to the operating room? Who are you going to have present? What staff are going to be there? Do you have ultrasound present? And do you have a cesarean section kit open or not? Over the years, I have actually simplified my practice completely in that I do use an operating room, but not because I think we're going to be doing an OR, just because I think you need more space. I have a team there and everybody's role is very specifically specified. To me, there's not a lot of skill in doing this. And so I tend to be the manager. I work a lot with residents and fellows. So I find I just need to be like the manager, managing the clinical situation. The clinical prowess to do this is not great. I tend not to use ultrasound. I have the machine there just in case, but I find it just complicates things. And this is actually very simple. And I do not have a cesarean section kit open because I think that often creates a self-fulfilling prophecy. Next slide, please. And the technique, I'm going to go through the 4 different techniques here, none of which is better than the others I've found over the year, but I think each one is good for a different clinical situation. And it may change, the clinical situation may change as the delivery goes on. Next slide, please. So the first one, this was what I learned in Oxford, the hands-off technique, which is basically you manage it, you let labor do most of or nature do most of the delivery. You deliver the first baby just as if it was a nullip. And after the first baby is delivered, you stabilize the lie of the second baby with maybe someone holding it. And then you let the second baby labor down in the pelvis. And the argument was you wanted to get the head well into the pelvis. So when the membrane's ruptured, you decrease the chance of cord prolapse. The problem with this is it takes a lot more time. And often abdominal stabilization is not practical for a long period of time. So effectively, you're just leaving it to chance that the vertex lie of the second baby will remain stable. The stabilize an ARM is the one technique I use most commonly now. I picked this up in Virginia, and this is where you deliver the first baby, just like a nullip, and then with the second baby, you stabilize the live vertex, and you very quickly rupture the membranes, so the head descends into the pelvis, and there's no chance of it changing to a transverse lie. But I tell the patients before I do this, before we start, that I do have a low threshold for operative delivery of the second baby, because sometimes that rapid descent of the baby can cause a prolonged deceleration. Next slide, please. There is the early rupture of membranes in the vacuum. I used to do this, and it was my preferred technique. It was the one indication where you could put on a operative procedure such as forceps or vacuum at a higher station, well, mainly vacuum at higher station, and because it was for this exceptional circumstance of a high-lying second twin. However, I have stopped doing this since this two-instrument rule came out, secondary to the Tower paper, that you shouldn't have a combined delivery, because if you use a vacuum, you've got a higher chance of it popping off when it's high with a lot of amniotic fluid. So I've now retired that technique. And then there is the push and pull, which a lot of my South African colleagues have used, which is where you convert the first delivery, the second vertex delivery, to a breech delivery and do a breech extraction. I do this very, very rarely, and only when there's a lot of amniotic fluid and when the second twin is high and stays very high and doesn't come down in the vertex presentation easily. It just seems to me counterintuitive and unnecessary to change it to a breech presentation unless you're in that last situation. Next slide, please. So I do the evaluation before the assessment, and basically I tend to, with a nullip, I use the stabilize and rupture of membranes. With a multip, I often just use the hands off, and only for a very high amniotic fluid volume and a slowly descending head will I consider the push and pull. And as I said earlier, I've got a low threshold for doing forceps delivery for the second twin. Next slide, please. Next slide. And this is how I go through things. It's just basically what I've said, and I don't think I need to spend more time on this. Next slide, please. So now we come to the second clinical case, which is basically the same scenario, except the second baby is breech. And this is my preferred setting, and I'm a great advocate of the breech extraction, which is actually a very simple procedure and easy to do. It is not technically difficult. It's all about having confidence. To me, it's a game of the mind rather than a clinical skill, and something that just becomes easier and easier as your self-confidence grows. Next slide, please. So for a second twin with a multip, it's easy. For primip, it's the same, but I just do an internal Kerlich version. I actually don't use ultrasound. I just know in my mind where the lie is. I have a mental picture. I just reach in, I feel for an extremity, I feel for the heel. If I don't find a heel, I push the extremity away and go to the other side of the uterus. If I do find a heel, I aim for the foot that's higher, i.e. the one nearer the anterior abdominal wall in the ceiling, because when you pull on that foot, the baby will come down automatically in the backup position. When I feel for the heel, when I've identified the heel, I just put 2 fingers around the ankle like that. I make a fist and I just pull the baby out with a long, sustained single traction. I don't rupture the membranes. They usually rupture spontaneously as the foot comes down. And you notice when the membrane's ruptured, the procedure gets much, much easier. So some people, if they find it's more of a challenge due to strength, to pull, rupturing the membranes will make it much, much easier. It's just a little bit more complicated to have 2 hands in the vagina at the same time. And I have always pulled, and the secret isn't to do one consistent pull. If you sort of pull and pull and pull in a jerky fashion, it only aids with you losing confidence and abandoning the procedure and resorting to cesarean section. Next slide, please. These are particularly, and I'm not going to go into these in details. I don't do twin deliveries with the second baby breech before 34 weeks because in some cases there is just spontaneous IVH, intraventricular hemorrhage, even if it's vertex. And I don't want to have the blame for that, even though it wasn't associated with a breech extraction. I never use pipers. Head entrapment is a thing of the singleton breech. It does not exist, or I've never experienced it for twins. Next slide, please. I counsel all my mothers. This is a simple counseling. If the first baby's vertex, we're going to go for a vaginal delivery unless there's a good reason, such as the second baby being too big or you preferring a cesarean section. If the mother does prefer a cesarean section, I do honor that request because if something goes wrong and they wanted a cesarean section in the first place, you're on a very sticky wicket. Next slide, please. And these are just what you need. You need good planning. You need to have confidence. If you don't have a lot of confidence, just get an experienced backup provider to back you up until you are. You have to have the patient agreeable, and you should always, in any situation, have the ability to do an efficient, rapid cesarean delivery. Next slide, please. We did this in our practice. I just wanted to finish off with a few slides here where we started off, made this a project for our hospital, the Brigham and Women's Hospital. We got a few champions. Next slide, please. And we targeted it. We found out what our providers wanted in the educational front. We gave them lectures. We did a simulation program. We launched a website. I ran my own dedicated twin clinic, and we provided a backup system for those providers that weren't confident in vaginal breech second twin delivery. Next slide. This is what we found over the years. If you look at the slide, basically our vaginal delivery rate increased over 5 years from 28% to 56%. Our cesarean section rate delivered dropped from 69% to 42% for all twins. And our elective cesarean rates dropped from 60% to 28%. I'm sure all of these figures are higher than in India, but we practice in America. And breech extractions became twice as common. And this was a very successful program. Next slide, please. And you can see both for the faculty practice and for the private practices, our incidence of vaginal delivery increased fairly dramatic with this program. Thank you very much. It's been a great honor to share with you. I only wish we were there in person, and I'm happy to answer any questions.
And thank you, Robin. And will you be here at the end of the session for a question, or you would like to finish the questions now?
I'll do whatever you want, whatever's most convenient for you.
Yeah, we can have 1 or 2 questions now, and more questions are there. We'll take it at the end. You
have mentioned it, Robin, about the choice of the second twin. You prefer to have vertex and breech rather than
vertex and vertex. I do, because it's actually simpler. It's done much quicker. I think most people don't want the second baby to be breached because they think it's going to be more complicated. But when you get used to it and you're very experienced, it's actually very simple. It makes the procedure much quicker. You're much more likely to have a successful vaginal delivery, and the mother's in a much better position afterwards because she hasn't had a C-section.
And if you predominantly the experience of our South Indians, or rather the whole of India, I think they will be very comfortable in handling the second baby as a vertex, and they don't have any issues in it. So they, if they really feel that that's going to be a problem, then they will think in looking for an alternative, like how you just said that it will be easier to go in for a breech. But I think most of us are very